the fellows and I picked a few cases that we thought would be interesting to discuss with you all. And really, we hope this is just a discussion. So how we're going to do this is we're going to present just a couple slides of a referral that we got, so from you all. And we're only going to put in there what came with the referral. And I'm going to ask you, just for the sake of discussion, does this sound like a referral that you would have sent or not? And the point of this is not to critique or praise your referrals, but just to have a discussion about it. And then I'm going to turn to the panel and say, you got this referral. What do you think about the information that you received? And what do you think, what's your thought process so far? And what tests would you plan to do with the visit? Because we have to decide that before we see patients when they travel 2 hours to see us. Then we'll give a couple more slides of what data was gathered in cardiology clinic, and then what some diagnostic testing showed, and then ask the panel again, like, now what is your thought process now that we've learned this information? And then like one slide with the diagnosis and a little pearl. So again, the point is not to pimp you all to try to see if you can come up with the right diagnosis either, but to give you all some insight into what it's like on our end to receive those referrals and what our thought process is, just as a way to facilitate some discussion. Does that sound okay? All right, so unfortunately, Megan McKittrick, our second-year fellow, was sick, so I'm going to present her first case, and then George Vera, our first-year fellow, will present to the next case, and we'll see how many we can do. We've got half an hour, we've just got a few cases. Okay, case one. So you're in your clinic. A 16-year-old previously healthy male comes in, and he's coming in because he went to the emergency department 3 times over the last several months for pre-syncope and syncope. He plays varsity soccer for his high school, and you're trying to get as many details as you can about these episodes. This is what the referral says. So the first episode and several after that were pre-syncopal, and some were at rest, but most of them actually happened right after playing soccer. So he was playing soccer, came out because it was halftime, or he was subbed out, and within a few minutes after coming out, he had either pre-syncope and then one full syncopal episode. He's played soccer since he was 5, and he's never had syncope while actually playing soccer, like running down the field. And with all these episodes, there was no clear prodrome. And in the emergency department, so as a PCP, you got the emergency department notes. And what you see in those notes are that there was a pretty thorough workup. There was a chest x-ray. They actually did an echocardiogram. They checked a troponin level to see if there was evidence of myocardial damage, and those were all normal. There was an EKG done that the adult cardiologist read as anterior infarct, but then the pediatric cardiologist later said was normal. They had a Holter placed, and those results are pending, but the ED provider was worried enough that they restricted the patient pending consultation with you. So this is the information that you got. And in your clinic, he's like, yeah, I feel fine right now. I'm not having any symptoms. And you do a thorough exam, nothing, no murmur, no irregularity to the heartbeats or to the heart rhythm, normal blood pressure, everything else is normal. So, show of hands. Does this sound like a referral you would send to pediatric cardiology? Who would say, yes, I would send a referral to pediatric cardiology? Just curious. Anyone say, no, I would actually do some more testing or refer to someone else? Anyone want to share a thought? There's no right answer, it's just for discussion. Would no one send a referral? You would send a referral. You would.
Yeah. I think I could almost guarantee that parents in this situation alone might probably warrant the referral, in my experience. Yeah.
Let's just say for a second, the parent's like, I don't know what to do. I don't know how worried to be about this. Would anyone, is this concerning to anybody? Yeah, so go back a slide. Yeah, I went quickly through those two. This one for the emergency department. We'll just get one more thought and then we'll see what the panel is thinking so far.
I think I read on the prior slide, it did say prodromal symptoms, or I just like if it was like finished exercise, totally fine, and then like almost like a vasovagal kind of pre-symptoms, then I'd be like, okay, no, you're good, unless the parents are like, you don't really need to see, you totally want to see cards. But if there was clearly nothing passed out, then I'd be like, okay, that's my thought.
Yeah, good. So you're wondering if there was a prodrome. Yeah, there was no, I mean, he just was running on the field, but then he came out and within a few minutes had these episodes. But There wasn't,
Yeah, it did say
oh, he did have prodrome?
on the
Sorry.
bottom, associated prodromal.
With the prodrome, okay, thank you. Thank you for clarifying that. Okay, so yes, there was some kind of prodrome, but this is all it says in the referral, right? It doesn't say like what it was, but there was a prodrome. Sorry, missed that one. Okay, so panel, what are you thinking so far? And let me, hold on just a second. So this is referral, so this patient's coming to you, they've been referred, they're coming either way. What cardiovascular test would you plan based on the referral and why? Yeah, this happens all the time. Go ahead.
Well, I would start by questioning where the echo was done, what they showed, and can I get the images? But I probably would not be planning, at least initially, on repeating the echo. I would definitely repeat an EKG because I like to do that.
And say a little more about what about the echo would make you say you might need to repeat it and why?
Well, if I want to be sure about the coronaries. And so if I can get the images and can confirm them, so I practice in Salem, so a lot of echoes are done at Salem Hospital, and I can usually get them sent over that morning and review them before the patient is seen. Sometimes I agree, sometimes I disagree with the reading. So I'm looking at more even than the report. But I'm not sure that I would order a repeat echo just for clinic workflows until I saw the patient and got additional history. But if I could get that information, then that would be really helpful.
Anybody else have anything to add to that so far?
There wasn't any comment about family history, so you don't know about like mom or dad. And so I think depending on I guess if I saw them in the clinic, what I learned from that, what other tests I would do, and maybe I would be thinking of a stress test.
Okay. So you're thinking ahead a little bit, but it sounds like you would also wait to get more information before automatically ordering more tests. Yeah. Go ahead, Maggie.
One.
Yeah.
My only other thought has to do with that Holter monitor, which most of the time when I see patients, I really want was results so I can look at them and talk to the patient about that too. But this Holter they put on and then restricted them, and it's only going to be a couple days, so I feel like it's garbage and I don't care what it says. That's my thought. I'm like, I'm going to do my thing and start over.
Okay. These are good questions or comments kind of segue to the next slide. So let's move to those. So, okay, now you're in cardiology clinic. You're getting some more history. So these episodes, several were witnessed. One was at school. And I guess the RN happened to be there during this test, like he was taking a math test or something and had an episode. And then another was, again, on the bench immediately after coming out from the soccer game or soccer practice. Again, multiple pre-syncopal episodes immediately following heart exertion. And then back to the family history, there's no family history that we know of arrhythmias, sudden cardiac death, or cardiomyopathies. And your physical exam is normal. I'm going to go ahead and give you the next slide, too. So in this particular patient's case, the echo was repeated, and it was normal, including having normal coronary arteries. The Holter came back within a couple days, and it showed frequent PVCs and a couple triplets that were kind of accelerated at 220, 255 beats per minute. And then a stress test was ordered, and that stress test showed increased PVCs and several ventricular couplets with exercise. So now back to the panel again. Now that you have more information, what are you thinking, and what are the next steps and why?
Now I'm thinking referral to Dr. Balaji.
Okay, so Amina's thinking of getting some more consultation with Dr. Balaji, who is our electrophysiologist. And why are you thinking that? What are you worried about?
It was just PVCs on the stress test, or were they like bidirectional or?
I don't know if they were bidirectional or not, but there were frequent PVCs.
Yeah, so I would be thinking about CPVT in this kid. And so I would restrict them until further evaluation.
Okay.
And the Holter's still tricky, right?
Yeah.
Because we see that all the time. Yeah.
Actually, we have a kid.
Yeah.
Yeah, so
I think the other thing I would think
go
about is
ahead, yeah.
ARVC in this patient. So you could, I mean, if you're waiting, Dr. Balaji's gone or whatever, you could do an MRI, to kind of get that, because the echo sometimes shows us evidence of it, but may not be the best diagnostic test if you have a high index of suspicion. So an MRI would be kind of the next level of testing.
So just to be clear, you're thinking of those two diagnoses in particular because CPVT usually has normal baseline EKGs and normal echocardiograms, and also arrhythmogenic right ventricular cardiomyopathy, which is a mouthful, also can typically have normal echo imaging, but sometimes with MRI we can pick up abnormalities of the heart muscle, but could have a normal baseline EKG as well. Okay, so yes, this is a rare thing that, yes, this patient did end up having a diagnosis of CPVT, which has come up a couple of times today. This is a pretty rare diagnosis, but this is something we need to be suspicious of if there's syncope or sudden events associated with stress. Sometimes they might have been labeled as seizures, but really stress of any situation that can cause an adrenaline surge. So taking a math test at school, playing soccer, getting asked to prom, who knows? And so any of these situations can theoretically trigger more ventricular ectopy and can sometimes trigger prolonged runs of ventricular beats, which can sometimes progress to ventricular fibrillation. And so the diagnosis is often caught when we're doing ambulatory monitoring or stress testing, and we're seeing a lot of ventricular ectopy in the right patient. There is genetic testing. I know this patient in particular that just had genetic testing that was negative, but still has a presumptive diagnosis of CPVT because like a lot of genetic diseases that we deal with, if we're suspicious enough, but the testing's negative, we say, we think you have a gene we haven't identified yet, and we're still gonna treat you as such. And so treatments include beta blockers, sometimes surgical sympathetic denervation, because again, that just takes away that adrenaline delivery, epinephrine, or the adrenaline delivery to the heart muscle and heart tissue. And so this is a patient that does see our electrophysiology specialist, Dr. Balaji. So we thought for this case, a clinical pearl is that red flags, and Mina covered a lot of this earlier today, but kind of particularly concerning details when it comes to syncope are if the syncope occurred during or immediately post-exertion. In this case, I know that slide said there was kind of a prodrome, but if there's no prodrome, as you all said, that should be more suspicious. The family history is really important. And if there's any other red flags, such as syncope plus a murmur or syncope plus something abnormal in the EKG, then that should raise alarms. And if there's seizures that really only happen during exercise, I think we need to question if those are really seizures unless they've been sort of documented somehow by a neurologist to be 100% seizures. Okay, that was fun. Any questions or comments on that case? Yeah, everyone's gonna be terrified, right? That is a rare one, but just kind of as an interesting case. Okay, let's talk about another case, and George is gonna come up and present case 2.
I can use this. Alrighty. So for case number 2, we're starting at the PCP clinic. This is a 16-year-old, also a competitive athlete, because apparently everybody is in Oregon. I'm from Chicago, where we don't have as many athletes. He is presenting to the PCP clinic for follow-up after hospitalization for a suicide attempt. He generally is feeling well, has been playing hard with basketball, but he feels like he is relatively out of shape from his usual. He has no history of mid-exertional syncope, but does have a history of syncope with certain stressful triggers, including having his eyebrows waxed, getting an injection for immunotherapy, or having a scope put up his nose at the ENT office. And 2 months ago, he had 2 to 3 episodes of new rapid palpitations that only lasted a few seconds. And he's had kind of previous syncopal episodes. All those that are mentioned were from many years ago. He incidentally was found at the PCP's office to have mild thyromegaly. His thyroid levels were a little bit elevated, and he was going to have a thyroid ultrasound scheduled for next week. His mom has some type of cardiomyopathy in the history, and he has a murmur.
Yeah, so this patient's coming in for follow-up from a hospitalization for suicidality, and all of a sudden there's all these other things coming out, and there's thyroid concerns and the family history, kind of all over the place. But we got this referral. So does this sound like a referral you would have sent to cardiology? Yeah, I'm seeing some nods. Okay, so what are the red flags that are making you think we need to have some more evaluation here? I'm hearing family history of cardiomyopathy of some type, murmur. Anything else? Okay. Stress-induced syncope with getting his eyebrows waxed. Yeah, okay. All right, why don't we go to the next slide. So panel, this is the information you got so far. What tests would you plan for this patient and why? Or not, or why would, maybe you wouldn't do any more testing yet?
He's getting an echo and an EKG, 100%.
Okay, and tell us a little more about your thought process. What is it that's you're most worried about?
Family history and murmur for sure. The fatigue and not being able to keep up also kind of raises my eyebrows a little bit. Could be so many things. Of
course, yeah.
But we see the bad and I think the bad, so yeah.
Okay, yep.
Yeah, I'd agree with Maggie. And I'm actually less concerned, I think, with the syncope because those are in situations where it sounds a little more vasovagal, but the family history, the murmur, and then maybe some exertional fatigue are raising more red flags.
And we know that mom has some type of cardiomyopathy, which if we knew more, that might be helpful, right? Which type she had, but based on what we know, we have to be suspicious. Yeah, okay.
Yeah, I'd agree. I was going to say, I don't know if we'd be doing serial evaluation. Hopefully we can find more information, but definitely enough to get an echo with that family history.
Okay. Okay, go ahead, George.
There's a question.
Oh, sorry, yes. What do you think, panel? I hear one yes. And what is the main thing that's making you worried, Maggie?
I think it's hard because we don't know what this is, right? It could be 100%, it could be nothing, but it could be something really bad. So yeah, we've got to just limit him and get him in quick.
And is that partially because we've got, we maybe vasovagal, but there is syncope for sure, and there's a family history of cardiomyopathy in a first-degree relative. Is that by itself kind of enough for you to say we should probably restrict until proven otherwise? Okay.
Yeah, the syncope history is not what's driving it. It's you tack on that family history, you have uncertainty, we don't have any sort of cardiac testing, we don't have an EKG, we don't have anything. The syncope history is the icing on the cake that is the family history.
Okay.
I want to make one point I think is important, just because, again, I'm a proponent of trying to get kids cleared as quickly as possible. This would be a situation, like, we usually don't like to get urgent referral, like, just urgent, and then, like, we get inundated with some of those, and some, as a cardiologist, we're like, are they really urgent? But I kind of feel like if this is something like he's just starting his season, or he's in the middle, like, to keep him out for months while we're waiting for testing, I think is a big disservice. And this would be definitely an appropriate time, in my opinion, to call, not just send the referral with urgent, because that could, get lost in the shuffle, but to make a personal call or send a message to us. I mean, that's what we're here for, and for this type of patient. And we can talk a little easier from the regional clinic, so we can try to fit patients in potentially a little easier. But this would be a situation where I think it's very appropriate for a PCP to call and make a personal phone call to a cardiologist and just ask to see if we can get this patient in sooner rather than later, so they're not just put on next available kind of thing.
Yeah, I totally agree with that. And this is the one where, so I'm down in Southern Oregon, so this is the one that the pediatricians would just text me and say, I need to tell you about this kid, and I'd get him in the next week or two. Yeah.
Is there any sort of outreach to more of the rural communities? I'm over in Eastern Oregon, so the closest town for us is Boise. Is there anything in like the river or
The Dalles.
the Dells? Okay.
And this could be a situation if it really is an access issue, because I think that's a really good point in rural Oregon, like to come all the way to Portland, or even from far eastern Oregon, or like we service Coos Bay, for example. Sometimes in that situation, I would say it might be appropriate to get an echo locally, understanding, and we would look at it or determine if we might have to repeat it. But especially if it's like we're looking for something like hypertrophic cardiomyopathy, dilated cardiomyopathy, those things I would expect a regular adult lab, even if they don't do a lot of peds, should be able to diagnose. And almost coronary, I'd be a little less, confident, but I think some of these potentially a local echo lab might be able to at least help in getting this kid cleared if they're waiting for a cardiology visit.
I was going to add to Misty's comment about urgency of the referral. I mean, I would question even in this case that, let's say we're wrong in our assumption that the syncope episodes don't sound that bad. And I'm leaning certainly just based on what they describe as a vasovagal. What if this is actually a cardiomyopathy? These could be aborted sudden cardiac arrests. So I think that there's even additional reason to say this is a really potentially very concerning history. Might be nothing, but there's enough there where, it's just built upon itself.
Okay, great. So the patient comes to cardiology clinic. Oh, yeah, sure, quick question. I know we have the PARS, and I don't know if we do e-consults yet, as far as
I think
I'm
we're still
aware.
working on the e-consult thing.
That'd be a good question for Lars too afterward. Yeah, ask Lars afterward.
Does the inpatient team do the e-consults, Lars? How's this work?
He's out in the lobby right now. Yeah. Okay, while we're getting him, why don't we move on to the cardiology clinic?
All
go
right,
ahead.
so we're in the cardiology clinic. He doesn't have any chest pain. He occasionally has some pain in his right arm and his right temple without a clear trigger. It's happened 5 to 6 times a year in the past few years. To dive a little bit more into his family history, both his mom and his maternal grandfather have a history of cardiomyopathy, and both also had arrhythmias. Mom had a history of ventricular tachycardia, and grandfather had a history of atrial fibrillation. His exam is completely normal. The murmur, gone.
Magically disappeared.
He doesn't have any other signs of volume overload, lower extremity swelling, jugular venous distension, or hepatomegaly. But we did get an echocardiogram that showed moderately decreased left ventricular systolic function, mild left ventricular dilation, but no other structural abnormalities. His EF was estimated around 49%, and his shortening fraction, which is another marker that we use for systolic function, was around 16%. And again, this is a 16-year-old competitive athlete, just to remind us of the context of this echocardiogram.
And I think, yeah, the mom's like, I don't know what it's called. I have some type of cardiomyopathy, and my dad did too. Is that right?
Yeah.
Yeah, okay. So based on this, do we have a suspicion for what's going on here, panel? I see a nod or two. Yeah.
Was it dilated? Did you say that?
It was low function and dilated.
And dilated, yeah. It's dilated cardiomyopathy inherited.
Yeah, dilated cardiomyopathy until proven otherwise. Yeah.
This is probably the situation where the adult cardiologist said, we don't need to do genetic testing, it won't help you out.
I've heard that so many times, it is infuriating.
Speaking of screening and genetic testing, go ahead, George.
So he does have a familial dilated cardiomyopathy. Mom did get genetic testing. I don't know if it was before this or after this.
It was after. I think it was after.
After this, thank you. She has a Titin mutation, which is one of the proteins that help form our muscle fibers in different parts of our body. She has a heterozygous Titin mutation that is deemed likely pathogenic, but he has not gotten genetic testing, so we're kind of just presuming that he's inherited this from his mom. Just to kind of add a little bit of extra flavor to just heart failure in general, we have started classifying heart failure into 3 separate categories instead of just HFpEF, which is preserved ejection fraction and ejection fraction greater than 50%, and reduced ejection fraction less than 40%. We now also include this 40 to 49%, which is where this patient would fall into, which is mildly reduced ejection fraction. And that really helps us as far as figuring out what classes of medications to kind of put people into, whether it's beta blockers, SGLT2 inhibitors, your mineralocorticoid receptor antagonists, spironolactone and eplerenone, ACE inhibitors, ARBs, Entrestos. Different kind of combinations of medications are indicated for different kinds of heart failure. He also had a Ziopatch and had no arrhythmias yet. So for clinical pearls, really all first-degree family members of patients with cardiomyopathy should have both genetic and clinical screening. For Titin mutations, more specifically, about 25% of familial cases of idiopathic dilated cardiomyopathy are related to Titin mutations. And this is from a 2010 position paper from the European Society of Cardiology Working Group on myocardial and pericardial diseases. It's a little old, but I love a good graph, and this includes both hypertrophic cardiomyopathy and dilated cardiomyopathy. And you can see here that we're really it's recommended to start screening early, around 10 to 12 years of age, and our screening frequencies change as we get older. And even though we don't all see adults here, I used to see adults, and we all see future adults. These screenings should continue until they're 50 to 60 years of age. So it's important as they leave your practice for them to know that they should continue to see an adult cardiologist, continue to get echocardiograms, EKGs, due to varied penetrance in these different autosomal dominant mutations. It's also really important because of family members, asymptomatic family members of patients with dilated cardiomyopathy, about 10 to 20% of those will have left ventricular enlargement that does not actually meet criteria for dilated cardiomyopathy. But once you have left ventricular enlargement, almost a quarter of those patients will progress to develop a dilated cardiomyopathy. And the earlier you start to catch these, the earlier you can put them on medications, and the earlier you're able to prevent the abnormal remodeling process that these patients can develop. The ACC, this is from the 2018 guidelines on hypertrophic cardiomyopathy, which is easily Googleable, but they differed a little bit for hypertrophic cardiomyopathy, especially when it comes to patients who have a known genotype that their family has tested positive for versus those who do not have a known genetic mutation. They can be anywhere from 1 to 2 years to every 2 to 3 or 3 to 5 years as they start to get older and older.
Yeah, so we start screening those kids in late, childhood, elementary school age. And one thing, just to add to your comment about screening in in older adults, the other time it comes up in my clinic is when it's a grandparent that had a cardiomyopathy, because all the guidelines say screen first-degree relatives. But I frequently meet parents who say, yeah, my dad had a cardiomyopathy. I had an echo down when I was 18, and now they're 42. And they haven't had anything since then. So they very well could have early signs of cardiomyopathy, but they haven't continued that screening. And if they were positive, then we'd start screening the kids, but it's a little hard to know what to do with the kids because they're second-degree relatives. So that's the other time it comes up that's important. So go ahead, James.
So this case reminded me of a patient that I saw before I moved to Oregon, and he had a dilated cardiomyopathy. And as I was getting the family history, this child had a severe dilated cardiomyopathy. Getting the family history, and then mom says, his dad had a myocarditis, and he had it when he was in his 30s. And, his brother had a myocarditis. So uncle and patient's father. And then they essentially really just thought they had a myocarditis. Family history of myocarditis, apparently. And so I just wanted to point that out, in that if you ask for cardiomyopathy, we might not get the right answer. So any other heart conditions is probably reasonable, and be aware of misdiagnosis.
Reminds me of another point with family history is I think the lay public will often use the term heart attack and what was actually a sudden cardiac arrest interchangeably. So, you get a family history of heart attack, which unfortunately in the United States is not uncommon to have family members with heart attacks. But I think delving a little more into that history, the age, the circumstances, because a 25-year-old having a heart attack, a little more different thinking, and would get more information about that versus the 60-year-old grandfather that had the heart attack, right? So, I think, again, thinking about how people use some of the terminology and how it's different than how we think about it.
Great points. I'd love to do more cases, but I do want to let you guys go on time. So why don't we give a round of applause to George and our panel for being put on the spot.